Now we're going to be talking about obstructive sleep apnea, and this is the breathing disruption during sleep that usually lasts at least 10 seconds and occurs a minimum of 5 times in an hour. Obstructive sleep apnea is defined as repetitive episodes of cessation of airflow, which is apnea, at the nose and mouth during sleep due to obstruction at the level of the pharynx. These apneas often terminate with a snort or a gasp. Repetitive apneas produce sleep disruption, and it leads to excessive daytime sleepiness. It's associated with oxygen desaturation and nocturnal hypoxemia, and usually this course is a chronic course. The systems that are affected with sleep apnea, of course, are the pulmonary system, but also the cardiovascular system and the nervous system as well. The incidence, predominant age, middle-aged men and women, predominant sex is male greater than female, 2 to 1. The prevalence up to 4% in men and 2% in women. And the prevalence is higher if the patient is obese and is hypertensive and/or. Risk factors are obesity, age greater than 40 years, alcohol and any sedative intake before bedtime, smoking, nasal obstruction due to polyps, rhinitis, or a deviated septum, anatomic narrowing of the nasopharynx, tonsillar hypertrophy is another reason or a risk factor for sleep apnea, obstructive sleep apnea, acromegaly, hypothyroidism, and some neurological disorders. General prevention of sleep apnea is weight control and avoidance of alcohol and sedatives at night. Can help prevent that airway collapse. Pathophysiology Osa, which is obstructive sleep apnea, occurs when the naso or oropharynx collapses passively during inspiration. Anatomic and neuromuscular factors contribute to that pharyngeal collapse. Anatomic abnormalities such as increased soft tissue in the palate, tonsillar hypertrophy, any cranial facial abnormalities can cause also OSA. The etiology, upper airway narrowing, may be due to obesity, that redundant tissue in the soft palate, enlarged tonsils, low soft palate, large posteriorly located tongue, the craniofacial abnormalities, neuromuscular disorders, alcohol or sedative use before bedtime. The common associated conditions are hypertension, obesity, daytime sleepiness, and that metabolic syndrome that you see with patients that are overweight. They have all three: overweight, diabetes, hypertension, cardiovascular problems. On diagnosis, you elicit a complete history of daytime and nighttime symptoms, and the symptoms can be insidious, and they can be present for many years. Usually when I ask my patients, I'll say, does your significant other or whoever you sleep with, do they say that you stop breathing, or that you snore, or do you wake yourself up because you snored, and you find yourself on your back? And a lot of times the significant other just comes in and says, he just stops breathing at night. And you look at the other factors involved. Maybe he's a smoker, drinker, and he's overweight. That abdominal fat puts pressure, on the diaphragm, and also that short neck, or a really large neck will also is another factor that you look at when you're looking at patients that have the sleep apnea. So our daytime symptoms that we may have is that excessive daytime sleepiness or fatigue, which is usually a cardinal symptom. The mild symptoms occur during quiet activities, reading, watching TV. Severe symptoms can occur during any kind of dynamic activities that the patient is like working or driving, and they have sleepiness. They're tired on morning awakening. They may have a sore or dry throat, poor concentration, memory problems, irritability, mood changes, morning headaches, decreased libido, and depression. Our nighttime symptoms could be the loud snoring, which is present in usually about 60% of the people with OSA. That's why I usually ask the significant other about snoring. Snorting or gasping that arouses the patient from sleep, disturbed sleep, and that witnessed apneic episode at night that usually their loved one comes in and starts complaining to the healthcare provider about. So we'll do a physical exam on these patients, and most patients have a normal physical exam. However, OSA is commonly associated, like I said before, with hypertension, obesity, or sleepiness. Focused head exam, head and neck, especially the short neck with a large circumference. The oropharynx, we have narrowing of the lateral airway wall. Tonsillar hypertrophy. I saw this one man, I couldn't even see in the back of his throat because his tonsils were so enlarged. Or macroglossia, also soft palate edema, long, thick uvula, high, arched, hard palate. You also see in a nasopharynx, you may see a deviated nasal septum and poor nasal airflow. So our labs, our initial labs, when clinically indicated, we look at the thyroid to evaluate for hypothyroidism. So we're going to do a TSH, CBC to evaluate the anemia and polycythemia, which can occur because of nocturnal hypoxemia. Fasting glucose in obesity to evaluate for diabetes. And it's very rare, but sometimes patients may, or healthcare providers may, order arterial blood gases to evaluate that daytime hypercapnia, which is increased amount of CO2 in the blood. So our diagnostic procedure for obstructive sleep apnea, the gold standard is polysomnography. It's the nighttime sleep study. And that demonstrates severity of the hypoxemia, the sleep disruption, and the cardiac arrhythmias that are associated with OSA, and that elevated end-tidal CO2 in the blood. The apneic episodes must last at least 10 seconds and occur 10 to 15 times an hour to be considered clinically significant. So the complete polysomnography is expensive. Health insurance may or may not cover the cost. I know for our patients at our clinic, we just have an overnight pulse ox symmetry because it's very cheap. They can go home with it, and then our physicians then look at how many times their O2 sat went below 90 and how long he can look at it and see how long it was. We'll also do PFTs, especially if they're smokers, and also chest x-rays or a CT, especially if they smoked for 20 to 30 years. On our treatment, our lifestyle modification is most frequently recommended treatment for mild to moderate OSA, and this includes weight loss, exercise, avoidance of alcohol, smoking, and sedatives, especially before bedtime. Weight loss has been shown to decrease the severity of symptoms in obese patients. So the the most effective therapy for mild to moderate and moderate to severe OSA is Cpap. So the treatment with Cpap utilizes that mask, the interface, and a flow generator to prevent that airway collapse, thus helping to prevent apnea, hypoxia, and sleep disturbance. Compliance. Compliance may be problematic in some OSA patients undergoing Cpap therapy because there's several different types of masks. I know that some of my patients have said, I just feel so claustrophobic with this mask. I just can't wear this mask. The short term, there's been some studies that they've done about the different types of masks, and there's what they call a nasal pillow is usually the preferred. It just sits on the nose itself and into the nares, so it doesn't cover the whole face with the mask. Medications are yet to be proven effective in treating OSA. Cpap is the gold treatment standard for OSA. Sometimes they may have to do surgery, a tracheostomy, craniofacial surgery. I've only had one patient that what they call it's a uvulopalato-pharyngoplasty. It's called UPPP, and I think it's on your slide. And I've only seen one other patient that has had that, but I've also ordered another PFT and another sleep apnea on him because it was like 20 years ago when he had that done, and he hasn't been followed up since. So we'll be seeing, exactly what's going on with him. On our ongoing care of these patients, let me just go back for a second. I know one of you, I think it was Cody's patient, had a patient that that it was like 30 or 40 years ago that he had. It was in the 70s, I guess, maybe before home Cpap. He had a trach put in because of how bad his obstructive sleep apnea was, and he still has that trach now. So our ongoing care involves, if our patients are overweight and obese, they should be encouraged to lose weight, and all patients must avoid gaining any kind of weight because weight loss alone can relieve some of those symptoms of OSA. So we want to make sure that weight loss, avoidance of alcohol, sedatives, and make sure that all our significantly sleepy patients during the day shouldn't drive any kind of motor vehicle or operate any dangerous equipment. Untreated OSA may increase the risk for development of hypertension, stroke, MI, cardiovascular disease, and work-related driving accidents. So it's real important that we address OSA with our patients, and just remember our clinical pearls. Our OSA is characterized by those repetitive episodes of apnea at the pharynx, when often terminating in that snort or gasping type sound. Laboratory polysomnography is the key to diagnosis. Cpap is the most effective form of treatment for both mild to moderate and moderate to severe OSA, but always remember that compliance can always be a problem with some patients. Okay.